Thank you very much. I'll just take a second to load my slides, and I would thank the organizing committee for the lung cancer update, Dr. Vijay, Dr. Aditya, Dr. Kumar Swamy, and Dr. Vikram for inviting me and giving me this opportunity to speak on this important topic, that is the ALK and the role of Alecensa. In fact, when we talk about the ALK, I think it is one of the success stories in lung cancer. It is one place where we have been able to defeat cancer very, very successfully. And it is a potent weapon against the lung cancer. So ALK inhibitors and how the ALK inhibitors started and the journey of ALK inhibitors is what is my topic for today. So I have 15 minutes, and please do let me know when I need to finish. I'll try to finish within those 15 minutes. Right. So what is ALK? ALK is anaplasia lymphoma kinase. It's an important driver in cases of lung cancer. And there are various methods of detecting it. The fluorescent in situ hybridization, or the IHC, the RT-PCR, and the NGS. So we can detect it by all these methods. So as we see that the ALK is homogeneously present in the population, though it may vary, the mutation may vary by ethnicity, because we know that the ALK may be positive apart from lung cancer, even in lymphomas, in childhood, like neuroblastomas. And as we do more and more tumors, we find that ALK may be present in ovarian cancers as well. But the incidence of ALK positive non-small lung cancer is relatively uniform, whether you're from Europe, US, or East Asia. Now, this is the study which was done in India, and we get a lot of variation. There has been as low as 2.7%. There has been as high as 13.2%. But what we can say safely is at least 3 to 5% of our non-small cell lung cancer will have an ALK mutation. The incidence may vary with regions of India, but it is higher with individuals who are light smokers, and especially in individuals with never smokers. So heartening to see, though the figures are less, but 75,000 patients per year is diagnosed globally with an ALK positive non-small cell lung cancer, especially never or former smokers, younger patients, once again females, and it is mutually exclusive when you compare it with EGFR and KRAS. The clinical characteristics do not always predict, though there are some telltale signs that we have detected from probably case studies, case series, and all. But otherwise, the clinical picture may not tell us that the individual may be ALK positive. So what started this was the Profile 1014 trial, and this was the landmark trial which told us that yes, we can treat ALK positive non-small cell lung cancer. And the drug that was introduced first was crizotinib, and we know that it was a molecule from Pfizer. This was the study which was a phase 3 open label randomized trial, which included locally advanced or metastatic non-small cell lung cancer who had not been exposed to any form of chemotherapy up front and had a good ECOG performance status. They were randomized into the crizotinib 250 milligram twice a day dosage versus the standard of care that existed at that time, that is cisplatin along with pemetrexed or carboplatin. The primary endpoint was the progression-free survival, and there were multiple secondary endpoints which included the overall survival as well. One thing that was important was that ethnicity, that is Asian versus non-Asian, as well as the CNS metastasis, was also used as a stratification for the study. And what we saw was alarming. That is a progression-free survival, which was unheard of, unseen, which started at around 9 months and continued as we went forward. A hazard ratio of 0.45, log rank p-value of significant log value, and the curves keep separating as we go forward. Also, the overall survival, since it was an intention to treat population, was also significant, and What is important is the 4-year overall survival rate, which was never heard of in lung cancer, was achieved with crizotinib of 56.6%. So the first study on this, yes, there were side effects, and we found out that the ALK inhibitors did cause problems in vision, diarrhea, edema. There were elevated transaminases, which many times did cause a stoppage of the therapy. But majority of the side effects were easily manageable as we learned to use this molecule. Also, we found that crizotinib, over a time period, the patient would progress. What was the cause of progression? The cause of progression was studied as various mutations that came. Though still 28% of ALK resistance is because of unknown mechanism, there are secondary mutations which are seen, and there are a number of secondary mutations which are seen. Copy number gains were another cause seen in 9% of the individuals, and other oncogenic drivers, predominant out of which was EGFR, MET mutations, RET mutations, which developed over a time period, were also seen. KRAS continued to be a problem in ALK positive lung cancer. So what happens to these patients who progress? So in came the second generation TKI, and ceritinib was the second generation TKI. This was again studied by the ASCENT-4 trial. This was a phase 3 trial. And once again, this was pitted against the chemotherapy, that is the pemetrexed with platinum-based combination. The primary endpoint was kept simple this time. It was only progression-free survival. And once again, alarming difference was seen as compared to the previous trial with crizotinib. The graphs start to separate at origin itself, and they continue to maintain even at 24 to 27 months. But remember, once again, the comparator arm in this study was chemotherapy, which by now we know is not the standard of care in ALK positive lung cancer. It was much, much inferior to the ALK. So once again, a significant p-value and a good hazard ratio. However, individuals with brain mets at baseline and individuals with brain mets without brain mets, there was a statistical difference. Individuals with brain mets did not do that well, and they invariably progressed in the brain after a period of 18 to 20 months. Also, the adverse effects were similar to crizotinib. However, it was heartening to know that the grade 3 side effects were less. Also, the toxicity of both ceritinib and chemotherapy was more or less comparable, though there were higher GI toxicity and liver enzyme elevation in the ceritinib arm. Also, the GI toxicity, like I mentioned, diarrhea, nausea, and vomiting, surprisingly was higher in the ceritinib arm versus the chemotherapy, whereas these side effects of chemotherapy continued, as we know. But why did these two molecules not work in brain metastasis? And it is very intriguing to know. And the reason for this is that the blood-brain barrier is made up of proteins which are the PGPs and the BCRP. And what they do is they scavenge these molecules. Once they scavenge these molecules, they try to engulf it, and somehow they don't like these molecules, so they expel them out. That is, they efflux these protein molecules outside. That is, so therefore, the crizotinib and the ceritinib do not penetrate the blood-brain barrier, and they are pulled out of it. So that the CNS exposure of crizotinib and ceritinib may therefore be inadequate to control disease in this location. And therefore, in both these studies, we found the maximum site of progression was the brain. So 46% in the crizotinib arm, 42% in the ceritinib arm. This was the problem that we were facing. And therefore, we needed a solution for the brain in such individuals. So in jumped another molecule called alectinib. And this time the study was different because the comparator arm was not chemotherapy, because we know the chemotherapy no longer is the drug of choice in ALK positive lung. So the alectinib was compared against crizotinib. And how is it different? What is important is alectinib is specific for ALK, much more specific than crizotinib. We know the crizotinib works in ROS1, MET, and other mutations. But what we require is a complete ALK blocker, which is alectinib. As you can see, it had a greater potency for ALK vis-a-vis the crizotinib, and also it is an in vitro kinase. That's why it's a second generation kinase and has a potent legacy as compared to the crizotinib. Also, the penetration to the CNS was better with alectinib. Unlike the crizotinib or the ceritinib, the PGP did not show that kind of love for this molecule and let it pass through the blood-brain barrier, thereby letting it act on the CNS disease as well. So the key difference that was seen with alectinib, and this is important, is the CNS penetration. The resistant mutation were less. It had a higher potency because it was against ALK, and it had a better selectivity. So the clinical application in the first line treatment was studied in these 4 studies, starting with the phase 2 AF001 study, the Japanese ALK study, the ALK study. These are all phase 3 study. And my favorite, and I think which is very pertinent to us, is the Alecensa study, which was done mainly in the Asian population. So let's see one by one about these studies. The ALK was the phase 3 study which started it all, and this was again in the first line, and alectinib 600 milligram twice a day was compared with crizotinib 250 milligram twice a day until progression. The primary endpoint was the progression-free survival. The individuals were stratified on those 3 important factors, that is the CNS metastasis, Asian versus non-Asians, and according to the ECOG performance status. The secondary endpoints was OS, ORR, and the CNS ORR. The data cutoff was analyzed from the start of 2017, first at 10 months, then again after 11 months, and then again after 12 months. So as you can see, the median follow-up, which started almost the same, 18.6 versus 17.6 at the primary analysis, start to widen to 27.8, 22.8 at 10 months. You add another 11 months and you get 37.8 and 23, and another 12 months, 48.2 and 23.3. So that is after almost 3 years of starting, the alectinib still works and is still ahead of crizotinib. So this was something which showed the superiority of alectinib. If we see the subsets, they were equally matched, but look at the CNS metastasis. The crizotinib, 38 out of 62, literally half, whereas in the alectinib arm, it was only 42 out of 58. Also, the time to development of CNS metastasis was lesser in case of crizotinib versus alectinib. This is the ALK's final mature investigatory assessed PFS, and as we can see, significant improvement, 34.8 months difference at 36 months, statistically significant, nearly 3 years progression-free survival. So that's why I mentioned ALK is a success story for us in lung cancer. If we see the exploratory analysis in the final PFS, marked difference which was seen. If we see crizotinib, hardly anybody reached the 4 years, and as you can see, you keep losing patients every year, and you keep losing patients more rapidly with crizotinib than alectinib. Even at 4 years, 43.7% of individuals were free who had received alectinib, something which is very, very scary. And these were the patient characteristics, and as you can see, this forest plot, everything favors the alectinib arm, and very heartening to see. This was consistent with the primary analysis, and the hazard ratio was statistically significant. So it gave you a progression-free survival of 25.4 months versus 7.5 months, and the ALX phase 3 trial without pre-existing CNS metastasis was almost 40 months. That is, you're giving somebody more than 3 years of median PFS, unheard of till date. And look at the difference between the graphs. I think the lesser said, the better it is. 84% reduction in the cumulative incidence of CNS progression. So if it not only had a better benefit in individuals who had CNS mets, but also probably causes prophylaxis against CNS mets. So very, very, very significant. So this is the updated
My
5-year
apologies,
overall
sir.
survival.
You are left. My apologies, sir. You are left with just 3 minutes to conclude the
I'll wrap up
presentation.
before that.
Thank you.
So,
Thank you.
it had a better 5-year overall survival rate. So these are the 5-year overall survival rate. Superiority for alectinib versus crizotinib. Yes, side effects were there. Since the alectinib was more potent, so it had more side effects. But what is need to remember is the treatment with alectinib went longer. So therefore, it is not a direct comparator with crizotinib. So whatever you give for a longer period of time will have definitely have a longer side effect. However, nothing that was too alarming. These were some of the side effects: nausea, diarrhea, vomiting, constipation. So these were the things. And this is how we treat ALK inhibitors. We started with crizotinib, went on to ceritinib, and then lorlatinib. There were other ways of treating. We don't have brigatinib so far, but I think the best way of treating these individuals are by giving alectinib. You get something around 34.8 months of progression-free survival. And if the patient progresses, you can put her on the third generation TKI, that is lorlatinib. I believe that is the next topic. So this is, I think, the correct way of going about. And remember, we are treating individuals with brain mets, without brain mets, delaying brain mets, increasing the PFS. So this is the NCCN and the ESMO, and for once the American and the European agree to the same. That is, alectinib is the preferred first-line ALK TKI in both these studies. So all these data has told us that this is better. So why alectinib? Demonstrated a longer PFS. CNS metastasis is the only ALK TKI which has demonstrated clinically meaningful benefit in OS, and this is against crizotinib, not against chemotherapy, and it is relatively well tolerated and well characterized, manageable safety profile which is seen. So this is the ALEX data, and I'll not go further because I've already told you about them one by one. So it'll be harping on the same: CNS, PFS, OS. And this is what Tony Mock presented, the Asian versus the non-Asian subgroup analysis. What he basically meant was the alectinib works even better in the Asian population versus the non-Asian population. So somewhere we draw the benefit out of alectinib. So last two slides. So what we firmly believe in oncology, doing now what patients need next. That is what we have done in EGFR positive lung cancer as well. And I think we should do it in ALK positive lung cancer. And my last slide is, yes, we can break barriers again in oncology, especially in ALK positive lung cancer. If we give a potent molecule upfront, beyond barriers, beyond expectations is what is the harmony of Alecensa or alectinib. Thank you for your patient listening. And